Good evening, everyone. Welcome to Incorporating Digital Radiography, a Necessary Transition. My name is Dr. Howard Golan, and I welcome you from my desk here in the great state of New York, a state that has been hit hard over the last couple of months with weather, but the spirit of New Yorkers and New Jersey and Connecticut and the whole tri-state area is a testament to the human spirit, and I thank everybody for coming tonight. I see a tremendous wide range of individuals from all over the world, including the U.S. and other wonderful countries throughout the world, and it's an honor and a privilege to be here tonight. Tonight's goals, tonight's presentation is about digital radiography. Those who are considering transitioning from traditional film to digital radiography, I hope this will be informative for you and will give you an interesting perspective into making the decision for the future. First and foremost, I want to thank Air Techniques for sponsoring this lecture tonight, this webinar. Air Techniques is a company that is in Long Island, and I have had the pleasure of working with over the last couple of years. We've certainly had their equipment in our office for a long time, and it has been an absolute pleasure and a joy to work with the staff and the individuals of Air Techniques, and I thank them greatly for sponsoring this lecture and webinar tonight, and again, it is a privilege and an honor to be here. So quickly about me, I'm in private practice in Williston Park, New York, which is on Long Island, on the North Shore of Long Island. I did an implant and advanced prosthetic fellowship at North Shore University Hospital in Manhasset. I am a member of the California Bar. I graduated from law school in 2007, so I think I have a unique perspective to the medical legal implications of some of these issues that we're going to talk about tonight. I am a graduate of the Alleman Center for Biomimetic Dentistry and a founding member, treasurer, and board member of the Academy of Biomimetic Dentistry, which is a brand new scientific organization that has been in existence now for almost 1 year. I am a master in the World Clinical Laser and Imaging Institute and an international lecturer on lasers, CAD/CAM, and other technologies. So it is a pleasure to be here. That is a picture of me in Lake Louise in Alberta, Canada, which is one of the most beautiful places I've been to. And again, it's a pleasure. So the objectives of this webinar tonight is to discuss the value of transitioning to digital radiography. Certainly there is an investment in doing so, as there is with many technologies today. However, I think you will see that there are values far and above the initial investment. Certainly, we want to talk of the difference between sensor technology and PSP sensor technology, the difference between wired sensors and the phosphor plates, and then obviously we can talk a little bit about integration and the return on investment of this technology. So the world is digital. I just came back from Germany. We had our boarding passes on our iPhones, and the entire world is going digital. Dentistry is no exception, and dentistry sometimes gets left behind in the digital world. But more and more, everything we do is on phones, is on the internet, is on digitized. There are very few things that we do today that we can't do digitally. And it's important that as dentists, we recognize the value of bringing digitizing and digital aspects to our practices. Dentistry is digital. Digital X-ray has been around for a long time. I mean, I've been in practice for 15 years, and digital X-ray has been around way before I started. We are now doing digital impressioning. On the right-hand side is CAD/CAM, is E4D, where we're doing digital crown impressions and digital designing of those crowns and cementations and production all in the office. We are taking digital implant impressions and full mouth impressions even for partials and dentures. We're using digitizing impressions for Invisalign. Our software programs for our scheduling. When I started in practice, my father, who I work with, used a book for a calendar, and within 2 to 3 years we switched to a computer calendar. So digitizing of dentistry is not new, it's not on the fringe, it's in every practice today. So why can't we do digital X-ray technology? film, processing, chemicals, dark rooms, former film. This is still a valid concept and something that I'm sure most of you still do every day. But there is a value to getting rid of these things. There's a value to not having to go into the dark room and lock the door for a couple of minutes to process these types of films, and having to deal with machines and chemicals and some of the things that we've used in the past. Film is what we grew up on. It's something that we've all done. We've taken X-rays in school. We've processed X-rays. We've used light boxes. We've received copies of X-rays from other clinicians, specialists, other dentists, and we're used to film. We're used to the nuances of film. But dentistry is now moving into a new dimension. On the left-hand side is the ScanX phosphor plate system that I have. This happens to be a picture of my system in the office. In our brand new office, we've actually created an alcove strictly for our ScanX technology. Putting X-rays on a screen, being able to manipulate those X-rays, digitizing diagnostics is a very, very important part of what I do every day, and I believe a very, very important part of what we do in the diagnostic process. It adds a massive value to both our diagnostic ability as well as educating our patients. On the right-hand side is a wonderful product called the Spectra, which is a caries detection device if you're into minimally invasive dentistry, if you're into early intervention, as I am, getting to cavities as soon as possible, getting to decay before it hits the dentin, if possible, and when we do locate decay, treating it as early as possible. The Spectra is a wonderful device because it allows us to map in a single picture the caries activity of the tooth in a single image. So it's a pretty exciting thing, and something that we're doing on a daily basis. But 2012, you can see, is really changed the way we look at our diagnostic images and how we do things. The past is, holding up an X-ray that's wet, coming out of the dark room, coming out of the developer and the fixer, holding it up to a light box, holding it up to a light, and trying to see and show patients what's going on. On the right-hand side is what we do every day, is on a screen, on a computer screen, being able to manipulate those images, make those images bigger, make those images smaller, make them darker, lighter, whatever we need to do to enhance both our ability to see possible pathology, possible dentistry that we can provide for our patients, but also it allows us to educate our patients in the chair, in front of them. When they see it on a screen, it becomes a massive, massive high-tech, what I call the high-tech perception. Patients coming in, and as soon as they see things on a computer screen, they immediately give the dentist some credibility. Now, certainly we need to keep that credibility, but it allows us to give the dentist a different type of credibility than ever before. So digital X-ray is a wonderful transition, and I think you'll see that it really is what I think is an important part of what we do on a daily basis diagnostically. So the whole concept of the paperless office is really an amazing thing. It's a transition that we did in 2008. All of your software programs, as almost all of the dentists that I know, have computer-based software programs to do their billing and do their scheduling, keep their patient information. And most of those software programs, if not all, are so robust that they support going digital, taking the paperless office, going to no paper or as little paper as possible. Again, we did it in 2008, and of course there's a transition phase that you have to go through. You have to get used to typing on a computer instead of writing notes on a piece of paper. But what the paperless office allows us to do is take a massive hold of the dental record. It allows us to access information as quickly as possible. We can pull up our X-rays on the screen as soon as the patient sits down in the chair. We can go back and forth to various X-rays from various times at different levels and different aspects of treatment at the touch of a button, and it really gives us a massive control of the dental record. There is an initial investment of money and time. There's going to be training involved, and there's going to be breaking of habits that you and your staff are used to over the years. But what's amazing about the digital record is it's the sharing of information both inside the office and outside the office. I can sit at my desk and my father can call me on the intercom or on the paging system, and he can say, look at this x-ray, and I can pull it up in my office while I'm doing something else and not have to get up, go look at it through a light box, and waste time that way. We can share information between various dentists within the office. We can share information between the hygienist. If a hygienist is seeing a patient and doing a cleaning, and she sees something that she's concerned about on the film that she just took, before I can even go in there and look at the patient, I can see the x-ray before I even walk in. She can say to me, pick up that film, look at it on the screen, and I can come in ready to go so I can tell that patient, okay, well, this is what we have to do, this is what we need to do, and it's an amazing way to be able to share information. It also allows us to share information with insurance companies. More and more, we have to send our claims electronically. By sending your claims electronically, you get paid faster. By sending your claims electronically, the insurance company can't say that it got lost in the mail. And when you send your claims electronically, you get paid a lot faster. And the reason you get paid a lot faster is you don't go back and forth asking for information as much. So as soon as we send in a claim, we can attach our digital film or our digital full mouth series or whatever we choose to send with the touch of a button, and we don't have to wait for correspondence weeks and weeks on end. So sharing the information with the insurance companies is a massive, massive value to the digital x-ray. How about when the insurance company does ask for more information and that we need to send an x-ray? Of course, certainly, we also deal with specialists. And I can't tell you how many times we get sent x-rays from other colleagues or other specialists that are not digitized, that are traditional film, and they are duplicates. And between you and me, I have found in 15 years of dentistry, never are duplicates as good as the original traditional film. But to share digital x-rays, to share a full mouth series, a Panorex, a single bite wing, or a PA digitally, all you have to do is email it to the specialist or email it to the insurance company. They can pull it up and they can look at it on a computer. In fact, it looks better on a computer than it does printing out. So we are really tired of getting traditional film from other dentists and other specialists because it's so hard to read and we can't look at them as well as we did the original films. Copying just doesn't work as well. So the paperless office is something that we have done many years ago. We haven't looked back, and we're very, very happy in terms of our ability to control the dental record. Of course, the big rumor, the big thing in going around dentistry today is this concept of the electronic health record, the federal mandates that are requiring dental practices to transition to an electronic health record. If you do a little bit of research into those mandates, though, it really comes down to dental practices that are going to bill Medicaid practices that are expecting federal reimbursement. They are going to be required to follow an electronic health record. And you can understand why. I mean, you can understand why the government is trying to do this. They want control over the health record. They want to be able to go in and make sure that Medicaid practices are billing correctly. They want to make sure that their patients, that the public is being treated fairly and being treated well, and be able to go in and look on computers is much easier than having to go through stacks and stacks and stacks of paper. So though there are not any federal mandates on dental practices not submitting to these federal programs where you have to switch to an electronic record, more and more states are going to be starting to require going to some form of electronic record. You can see, at least in New York State, they're requiring insurance companies to accept electronic claims, And you're going to see that more and more throughout the country, where states are going to mandate, either from an insurance perspective, a third-party carrier perspective, or individual dental practices, that we switch to an electronic health record. So I think it's really important that we look at that from a government and regulation perspective, that eventually we will all have to go to some form of electronic health record, that the public health demands for this type of technology is going to be overriding what we as clinicians may want to do. So you want to think about switching at some point, and this is no better time than the present to go ahead and do that. So what is the value of digital radiography? Well, efficient and consistent image acquisition. What does that mean? Well, you take an X-ray, okay? The sensors, the plates, they are what they are. You put it in the machine, you use the sensor as a acquisition unit, and it becomes a very consistent process. You do not have to worry about ratios of chemicals. You do not have to worry about machines with rollers and mechanical means to process film, which can break down. How many times did we walk into our darkroom and our processor wasn't good and we had to use the tanks, or we had to do a Panorex and the Panorex didn't fit in the Perio Pro, the machine, so we had to go use a tank, and the chemicals were cold, or they weren't cleaned properly, or the ratios were off. So in terms of processing, we can't tell you all those times in the past where the x-rays just kind of didn't come out right, where they were left in the developer too long, or the fixer too long, or the chemicals needed to be changed. Well, you don't see that as much. I mean, certainly there can be problems with sensors, there could be problems with software, but for the most part, it is a very efficient and consistent image acquisition. For me, the number one value of the digital radiography concept is record keeping. I can't tell you how many times in the past we put a single film in a coin envelope, put it in a record, in a chart, and one day that x-ray is no longer be found. You find them on the floor. You find them sticking together. You find them in between nooks and crannies of different pieces of paper. It is very difficult if you want to pull one up and you have a patient that you've been seeing for 15 to 20 years and you want to pull up an x-ray. It's very difficult sometimes to find that x-ray, and you have to dig during the procedure looking for the film. So the record keeping is a wonderful, wonderful, wonderful way with digital radiography to be able to pull up an x-ray quickly, to access it, to use it, and really it makes things much better, and we don't give record keeping and x-rays a second thought. Record sharing, we talked about being able to, if an attorney comes or wants x-rays, both positively and negatively, whether it's a potential lawsuit or not a lawsuit, if we have to send it to our malpractice insurance company, if we have to send it to a third-party paying insurance company. It is very easy to say to my staff, okay, pull up the x-ray from here and be able to send that, and send it quickly. Exposure dose. We'll talk about that in a little more detail. Image manipulation, we'll talk about that in a little bit, but the ability to make light dark, bigger, smaller, calibration, measurements, all those things allow for digital radiography. And then on the same way for record keeping, which is a wonderful, wonderful thing, and I value highly, the second thing I value highly is the be able to diagnosis and patient education. It is one thing to show a patient a film on a light box and show a PA at the size that PA is. It is another thing to blow that up 3, 4, 5, 6 times its size, put it on a TV screen, a 42-inch TV screen or a large computer screen, and be able to educate and diagnose and show patients what's going on in their mouth, be able to manipulate that image and make it darker, make it lighter, so we can see things that we couldn't see before. That is without question the massive value of digital radiography. When we talk about patient education, a lot of what we do in dentistry is not and probably never will be appreciated by patients. We got to get them to value what we are doing. We got to get to value what our dentistry is and how we're doing it and why we're doing it. And being able to put things on TV screens and show them visually really makes a big difference. And then we talked a little bit about the high-tech perception. About 15 years ago, I walked into I sent a patient for a root canal, and the patient came back from the root canal, and I said to her, "How was the root canal? Did you do okay?" She goes, "Yeah, but the plasma screens were amazing." And I went over to that endodontist's office, and he had plasma TV screens, and this was before plasma TV screens were as ubiquitous as they are now and as cheap as they are now. And he had them in every single room. And every single room he had that x-ray with that periapical pathology sitting right up there for that patient to see. And right then and there I realized that being able to educate people and put things on the TV screen is an important part of what we do every day. And I have found that patients immediately when they see an office that has that kind of high tech, where you can email x-rays, that you can take x-rays quickly and easily and see them on a computer screen, gives you a leg up in the battle of winning against making sure that patients understand and appreciate what we do. So again, efficient image acquisition. Well, it's faster processing than traditional film. If you have a wired sensor, it's immediate. If you have a phosphor sensor, a phosphor plate sensor, then it is a couple of minutes, but nowhere near what a PerioPro would be or a processing would be. In fact, in my office, we stationed our ScanX system very immediate between the multiple operatories, and within a minute, that x-ray is processed. You're not relying on chemicals or imaging processor machines, virtually no maintenance. I mean, certainly, everything has maintenance in some way, shape, or form. When we talk about endodontics, when you need to have that PA look at and check that file placement as soon as possible, it is wonderful to have a digital x-ray system where you have very, very fast processing. So endodontics is important. And oral surgery, you want to take a film quickly after you take a tooth out, make sure the socket is clean from any root tips. You don't want that open wound there. You want to suture that as fast as possible, whether it's implant dentistry where you want to check positioning, you want to check nerve position, you want to check with a guide pin. All of those things are important in the process. So anything that we can do to get that image quickly is very, very important. Record keeping, and elimination of lost films, stuck together films. Certainly there are potential problems with software, but with proper backups, you should not have to worry about your images. Let me go back again. I went too quickly. So elimination of lost films and stuck together films, films on the floor, films getting in one chart versus another. All radiographs for that patient right in front of you. So if you want to find their full mouth series, you pull it up on the screen. If you want to find films from 3 years ago, you scroll through it and you find it very quickly. Integration with practice management software. Most of your practice management softwares, probably if not all of them today, are able to integrate x-rays, integrate software programs, or you can get a third-party software program and bridge between the two or keep them separate. We happen to keep them separate in our practice because we didn't want to burden our software program with too much. Immediate acquisition into the patient's record. You pull up the patient's record, you pull up their x-ray record, you put it in, it's done. It's mounted within the software program. You don't have to wait and put it on a rack and let it dry or put it in a coin envelope and make sure that that gets back into the patient record. So it's important that we understand that keeping x-rays for both a medical legal perspective and a patient care perspective is very, very important. And then it's easy to copy and share. When x-rays are requested, either by the patient's insurance company, attorneys, colleagues, specialists, we can do that. We had one today where a patient was at an endodontist and he left the x-ray in his house. We printed it out for him. He didn't take it to the endodontist. We were able to immediately email that x-ray. We didn't fax a copy of it, which they can't see. We emailed a beautiful image, a JPEG image, where he can look at and manipulate in his own software program and look at those x-rays just as if I took them, he took them in front of him. And that's important because, as I said to you, copying of x-rays, copying of films, I've never really been able to value the copying of films, and we get these films from other dentists and other clinicians, and they're almost undiagnostic. So it's important that record keeping is understood as a value of digital X-ray technology. Legal issues. One is you have an X-ray record. Even if you don't put every X-ray that you took into the patient's chart, into the progress notes, you have, when digital software, you have a record of every X-ray that was taken. So there's no real concern that a patient can say, well, he took this, he took that, because we have it in the patient record. As soon as that X-ray is exposed, as soon as it's processed, that goes right into the patient's record, and there's a digital record of it. We talked about malpractice insurance companies. We talked about the attorney and expert witnesses. As a lawyer, as an expert witness, as somebody who reviews cases, I can't tell you how many times I have to go to the attorney and say, look, I cannot use these X-rays. These X-rays are useless. These copies are terrible. They are undiagnostic, and they do not help the dentist in any way, shape, or form. As soon as I get a digital photo, I get on photo paper or I get them emailed to me, then I can use those X-rays and help the dentist in those legal issues. So if you want your attorney someday, and we're all going to have to do that, it's at someday we're all going to have to deal with a legal issue in one phase or another. Let the legal people help you. Let the expert witness help you, and make sure that your X-rays are the best that they can be. There was a question about formats like TIFF and JPEG and bitmap and all those types of other things. I am not an expert in software. I'm not an expert in IT. I agree with you. There may be better formats than others. What we do is we export our when we export our X-rays from our software program, it gives us a choice. So I use JPEG as sort of a generic thing. I understand that there are other formats like TIFF and PNG and bitmap and all those others. So you can use whatever one you want, and if there's one that is specific to that, that's better than others, then you certainly can use that. So that's a good question. Legal issues, again, again, I can't stress it enough, as an expert witness, as an attorney, as somebody who goes through these records and is trying to help the dentist and try to get rid of these types of suits, got to see those films, got to see the endodontic fill, got to be able to see where the post is, got to be able to see the apex. It's just one of those things that we have to deal with. And as an expert witness in court, I can't tell you how many times we've seen X-rays and we've shown these X-rays to the jury. We can't blow them up because they're terrible and they look terrible, and it's going to look bad for to the jury if these X-rays are poorly processed or you can't read them. So it is. As when I teach about other technologies, I always talk about the potential of lawsuits and how it looks in front of a jury. And when you're digitized, when your record is digitized, it makes a whole lot of difference. So just keep that in mind when we go through this. Record sharing, again, the concept of email, whether it be a JPEG or a TIFF or a bitmap, email is a wonderful way. I have found that these even digital films are better viewed on a computer than viewed anywhere else. So, we actually ask dentists who are sending X-rays for a patient to send us an email of the film. Like specialists, they print us a report out, and actually we like to have the email. We actually like to have the X-ray emailed, and then we put it in our record in our X-ray software, and we label it from the specialist if we need that X-ray, or we can get a report from them. But in terms of sending copies, immediately copy the patient. A lot of patients today want their films to keep a record of it, so we send them out very quickly. If they want it, we give it to them. There's not a lot of cost to it, so it's very easy to do. And we talked about the medical legal implications of all this. So this is, I put this picture in because this is I don't know what to do with this file. These are X-rays, as you can see, that front picture there. These are X-rays that people sent us that are digital X-rays, but instead of utilizing the concept of email, which makes it a lot easier to view and manipulate, they print them out for us, and then we have to scan them into our computer. And even though they're on digital X-ray, they still still send us paper. It's kind of odd, but I think that we should all consider using email as our way of sending our films. We put personal and confidential in the subject matter, and we send the X-ray through our through our software program to comply with HIPAA. But a lot of these films in here, there's a lot of regular films, there's a lot of copies of old films, and it's hours of scanning to get into the computer. But it's important that we understand that record keeping is an important part of what we do. And I want to stress that enough, because if you're going to get into digital X-ray technology, which I hope you will, I think it's important that you understand the ability of record keeping. So when we talk about digital X-ray technology, it is well established that the exposure, the dose of radiation to patients with digital technology is much less than what traditional film is. We know that digital X-rays are a small part of the background radiation and the total radiation that patients get every day. However, it is still a very, very big topic. At least 3 to 4 times a week, we have patients that come in asking us about our X-ray policy, about digital X-ray technology versus regular film, and don't want to take X-rays. And we have to educate them as to what it is. So if we can keep our exposure low, if we can lower our radiation dose, our effective radiation dose to our patients, then everybody wins. So we know that it's anywhere between 50% to 80% less radiation. There's no absolute. We can't measure the actual dose that we're getting to patients, so we measure it in something called effective dose, which is what we think we're giving the patient. So it's what they deliver, and then we take into account different organs and things like that. But there's also other variables. Obviously, the quality of the sensor and the image that you get, and whether you have to go higher or lower into that process. The quality of the X-ray unit, we had multiple X-ray units that were very old in our old office, and they all delivered completely different levels of radiation, and we had to adjust our exposure for each individual unit and calibrate it and titrate it for our sensor technology. Then we have the quality of the titration of the operator, which we talked about. But with digital sensor technology, you don't need as much exposure, and due to the software enhancements, you can keep that dosage lower because you can manipulate that image in a positive way. So we know there's studies and there's much research out there that the ability of digital radiography versus traditional radiography is less. There's no question about it, and we want to be able to capitalize on that to ease patients' minds that we're not doing more harm than we need to. So one of the big topics that people want to discuss is the different options in terms of digital X-ray technology, and there's really 2 main options that you have. One is photophosphor plates, and one is sensor technology. Both are technically a sensor. It's how how one takes on the images. And there's multiple different changes in terms of which one you want to choose. There's certainly acquisition time, ease of acquisition, image quality, flexibility, integration, cost benefit, and upkeep. So let's talk about the traditional, which is kind of a paradox, but the traditional digital sensor. This is the sensor that I started with 12 years ago when we started with digital X-ray technology. It is a sensor that has a volume to it. You can see that there's a thickness to it. It's wired. We haven't figured out a way to get them wireless yet. And so they are without question durable. They're made to be durable. They give you an instantaneous image, which means as soon as you expose it, it is wired to the computer, which will give you an instantaneous image. So that's an advantage when you're looking at like endodontics, where you can get something very, very quickly. They are tethered to some form of acquisition unit. So either they have to be tethered to the main computer that you're going to be storing the images on, or at least networking to, or there can be a free-holding tablet, computer, or some other type of device, and then you have to move those to the computer themselves. there's obviously a thickness to them, and that is probably the biggest downfall of the sensor technology, this type of sensor technology, because this is where we moved to the phosphor plates almost 10 years ago. We started with these types of sensors, and what we found, it was very, very challenging for our staff to take a full mouth series efficiently, quickly with these sensors. The positioning of these sensors is so difficult sometimes because of patients' mouth. You have patients with high vaults, you have patients with tori, you have patients with small mouths, you have gaggers. This becomes a big, big, big challenge. You're also limited in the amount of sensors, shapes that you can buy. So, for instance, if you want to get a Panorex image, you have to buy a digital pan that will acquire an image separately than your PAs and your bite wings. As we'll look in the phosphor plates, you can buy a separate phosphor plate strictly for Panorexes and process it in the same machine as you do your PAs and bite wings. So that is a big deal when we talk about integration and we talk about a busy practice. How many sensors are you going to buy? So if you have 5 or 6 operatories taking x-rays at the same time, how many sensors do you need to keep up with that? We found in our busy practice that it was very difficult from a technique and from an integration perspective to be able to integrate these sensors. But there's no question that the images are beautiful. I'm not going to tell you one way or another that one image is better than another. I think you have to make that determination for yourself based on the systems that you see. And then you have upkeep. These sensors are high technology. They are very, very complicated wiring and things inside them. And when that warranty wears out and somebody drops them, a patient bites on them, that sensor doesn't work, now you have to go and try and move on, if you will, and either buy a new sensor or get the warranty program. And so even though there's a large initial investment, it is possible down the road that that investment starts to multiply as you go through. So it's important that we want to go to the future and really change what we're doing with digital technology, but we need to understand the differences between the two things. So that's where I think sensors are, is that they're a wonderful technology, but they do have some drawbacks. The phosphor storage plates, as you see here with the ScanX system, is a little bit different in what we're doing. Because what this is, these are regular film, and they act like regular film. You put a barrier around them, sort of similar to what a regular film is, and your patients feel like regular film. They're actually thinner and actually more flexible than regular film. You put them in a barrier, and then you expose the film with regular rings, with regular acquisition that your assistants and your hygienists are normally used to. They come in all different sizes, from pedo all the way up to Panorex sizes. And then you basically put them in a box, you undo the barrier, you put it into a transfer box, and you send that transfer box to the processor. If the patient is already loaded onto the processing screen, it literally takes a couple of maybe 2 or 3 minutes, really actually 30 seconds to get a single image. And if you want to process a full mouth series, that full mouth series gets processed in a couple of minutes. Infection control is very easily dealt with. You have, again, these disposable barriers where these plates then go through. And then once the x-ray is exposed, you rip the barrier, you drop the plate into a transfer box, take your gloves off, put the transfer box, and bring it to the processor. They are very thin and very flexible. Your patients will not notice any difference between transitioning this and transitioning into your digital system, because your staff is going to take them the exact same way. There is a processor required. So with the scanner actually processes the images and sends it to the software. In the phosphor plate, there needs to be a separate scanner where you put these plates, you drop them through, and then you go ahead and you wait for the image to be processed. The processor has limited moving parts. We've had our ScanX system now for close to 10 years and have not had literally any repair or issue with it. We've had no issues with the processor at all. The processor is outside the mouth, And so infection control is not a big deal. And because you can buy multiple plates, you buy multiple full sets, it allows you to move on and do multiple patients with multiple imaging at the same time. So this is the ScanX. This is the newer version that Air Techniques has come out with, and you can see there's different slots. You can put in a Panorex that kind of covers all the slots at once, and then you have a 4 different holes where you drop the different images in. It allows us to do things very quickly and very easily. So ScanX has been a wonderful addition to our practice, a busy practice. The only thing we give up is we give up the actual instantaneous X-ray, where if we're doing a working length film or a master apical cone film, and we go ahead and we take that image. But again, we've positioned our scanner very close to our operatories, so within 2 to 3 minutes, not even, we'll have at maximum, we'll have our image processed. Image manipulation, obviously endodontics, looking for caries, and patient education. So let's look at a couple of cases. So here's an endodontic case where we're checking our gutta-percha film, and I don't know about you, but no matter how good images are, sometimes it is very challenging to determine the apices, the apex of especially maxillary teeth, where you have multiple superimpositions. You have the zygoma, you have sinuses, you have bone, you have soft tissue, all in that 2-dimensional image. So the ability of a digital X-ray system to now manipulate that image, to change it from black and white, allows us to wonderfully look at and give us a better image so we can see if we're happy with where our working length is and our master fill is. So image manipulation for endodontics is an example. Here's another example where we can then calibrate. We actually can use the size of the film as our standard, and we can actually determine and measure on the film exactly where our working length is. You know, with traditional film, there's a elongation and there's different distortions that are involved with X-ray technology. To be able to measure on the film and use that as a standard gives us a better understanding of our measurements and our size. So it's wonderful in terms of image manipulation. Then you have patient education. Patients learn visually. There's no question about it. Being able to put things on a screen and show them there's problems. We talked about the high-tech perception again, magnifying the image to demonstrate what we need. And when patients see what the problem is, then we do. All right? Half the problem with dentistry is getting patients to value what we want to do for them, because a lot of times they're in no pain. And so it's nice that when we can show them, well, look, this is what's going on, and it's clear because it's large and it's visual, it then gives us a wonderful job to help us educate our patients. So here's a wonderful example of showing patients periodontal issues. We see a furcation involvement. I'm going to put my cursor on so I can point. We've got furcation involvements. We've got vertical bone defects. We've got potential periapical endoperio lesions. There's a lot going on with this tooth. We've got a crown that doesn't fit well to the gums. We've got poor contouring. So you can see we've got big posts with potential fractures. There's a lot of potential problems going on with this tooth. And to put this small little film on a light box and show them that would be very, very, very difficult. So being able to put it large on a screen and show people is a great thing in terms of patient education. And then you can put a full mouth series on a screen and you can show them what their mouth looks like as a whole, but then really zoom in and show them what periodontal disease is doing to their teeth and doing to their bone. And there's no question that by able to put these on a screen, it gives us a lot more credibility in the diagnostic process. You know, obviously we want to show people what's going on. We want to give them options. We want to show them what we can and can't do for them. And when we can show them these types of things, where we show what's the restorability of this tooth, and we explain to them, well, look, you have no pain, but look at this problem here. Look at this leakage, and here are the problems that I have in restoring it. You know, maybe this is an implant. Maybe this is a crown lengthening. Whatever that is, it really allows us to provide an education for our patients. So we've talked a lot. We've talked a lot about different topics, and there's sort of a limit to how far you can go into digital radiography in a general sense. But in conclusion, the move to digital imaging is important as it improves patient care, improves the delivery of care, and reduces the radiation to exposure to the patient. It dramatically improves patient education, which will consequently increase treatment plan acceptance and increase production. Digital radiography is an initial investment and a short learning curve that will ultimately pay off in the end, and phosphor plate sensors provide efficient, patient-friendly, and more cost-effective acquisition than do the traditional sensors. So I thank you for your time. We'll ask, if you want to ask some questions, I'll be on the line for the next couple of minutes, and I have some questions here that I got to read through to make sure that I get everybody and answers everybody's question. So if you have any questions, you're more than welcome to ask it. So one question is somebody who's been practicing for a while, and we can't decide whether we do a server-based practice management or a web-based practice management. I understand any digital radiography software must be compatible with the practice management software, and I'm truly a paper office. Any suggestion to help me facilitate a decision would be appreciated. So one of the things that this gentleman is asking is you do not have to have your X-ray system, your digital X-ray system, in perfect alignment with your dental software system. In fact, in our practice, we've separated our X-ray imaging software from our practice management software. We didn't want to burden our practice management software. So what we do is when a patient comes in, we actually pull up the practice management software and we pull up the X-ray software. We go back and forth between the two. So you don't have to do that, and make sure they don't have to necessarily be compatible. You can use any digital X-ray system and keep it separate. And a lot of IT guys and gals that I've talked to actually recommend not incorporating the digital X-ray software into your practice management software. In terms of the rest of the stuff, that's a little bit outside the scope of what we're talking about. In terms of sending reports and sending X-rays for our patient, it is very, very challenging. We have to make sure with HIPAA that we comply with sending emails for patient confidentiality. The best way to handle that is to send those emails and reports through your practice management software. So what we do is we can import it into our practice management software and send an email through there which complies with HIPAA. How can you tell when they need replacing? What is the usual life expectancy for a type 2 film? So with the phosphor plate, there is a lifespan, which is certainly a downfall. But what it does is you will tell the difference because the images will start to decrease in value and in quality. And so it's important that you look at those films, and if you start to see negative changes in the quality of the image, you throw the plate out and you incorporate a new one. But right now, we don't have the technology to know exactly when those plates are out of their lifespan. My guess is that's going to come in the future. I am a dental assistant at an endodontist office, and we have paperless digital X-rays. Like you mentioned, is very helpful, fast, and efficient, but I usually struggle with sensor placement since it is hard and not flexible, and patients have different mouth sizes and shapes. What's your advice? Thank you. Well, the advice is you should go to phosphor plates because, until they come out with a flexible wired sensor, I think it's going to be very hard. There's really no good way. You just have to struggle through and get them in and get better at taking your films. We don't have those issues. Now, I know that Air Techniques does make a system that is a smaller ScanX processor that you can actually place within the operatory, so you don't have to walk out. So it's essentially almost an instantaneous, where you take the film, you take off the barrier, and you put it right into a small processor, right into your operatory. So that may be an option for your endodontist office. Another question is, bear with me here. With a sensor, you assign the location of the film prior to take it. With the plates, do you have to view them and assign each location after they are processed? Great question. What we do with our phosphor plates is we will put them out on a sheet, and we will assign a position for them. We open up the mount in our software program, and we will enter them as we go, and we will put them into the process, and they will automatically enter into each of the mounting slots, if you will, on the software, as long as we put them in the right order. So we do have to put them in the right order, and we can do that, and that's not a problem. It just takes a little bit of practice in terms of getting the system down pat, but it's very easy to do. Next question. How do these two systems differ in initial cost? Janine, thank you for your question. I'm not a cost guy. I'm a dentist, so I speak about this stuff. I'm not sure where the cost factors are today. It depends on dealers and things like that. So it really depends. You need to call your dealers and your providers and see what it is. One person wanted to mention, who is an advocate of the phosphor plate technology, that the phosphor plate sensors are wireless, right? They are like regular film. They are not tethered to a computer. So I just wanted to reiterate that. Which is more expensive, sensors or PSP in general? I think that the sensors are more expensive. I have heard stories with friends of mine that they get 1 day out of the warranty phase and the sensors don't work anymore, and now you either have to buy a new one and they won't warranty them anymore. You can't even get a service contract on them. I don't want to speak for any specific company because I'm not sure, but I hear the stories about it. With the plates, if it's a bad plate, we throw it out and we move on. And even if it's a bad plate, the image is still diagnostic and still has a quality to them that we can move on. Next question. I couldn't understand how we use the sensor to record an image. Please repeat how we get the image. So, just quickly, how do we get the image? Well, you put the sensor in the patient's mouth. You expose the image. The image is captured digitally on that sensor, and it is sent to the computer, both either with the plate or the wired sensor. In terms of the actual details as to how those plates work, that is far beyond the scope of this presentation. Next question. A company rep informed our staff that they do not need a lead apron on the patient as the digital panoramic generates negligible radiations. Our staff was concerned about the thyroid collar that shows in the Panorex. What do you say? That's a great question. I am a big believer in protecting the patient in any way possible. The first step before you do anything is you should call in a radiologist specialist, a technician, whoever measures it for your state, if your state requires that, and get an idea of the actual scatter of the Panorex of the X-ray system, and wear badges so you can actually know for sure. And if a patient doesn't want to wear one, they don't have to wear one. I know that we can take good Panorex images with a lead apron and a thyroid collar on and still get the things that we need. Sometimes you can't, and you have to inform the patient of that and what you can and cannot see. But I'm a big believer in protecting patients any way that I can. Next question. Part-time dentist seeing 15, 20 patients a week max. Will it be cost-effective to go digital? Absolutely. I don't care if you're a part-time dentist or a full-time dentist. Digital X-ray systems will pay for themselves over time in terms of the cost of the chemicals, in terms of the processor. You will probably diagnose more dentistry. You will get better patient acceptance, and even with those 15 to 20 patients a week, you will definitely pay for that very, very easily. Doctor, you haven't told us anything about the conditions of digital X-rays in the office, as I've seen many digital X-rays from many different sensor types that were terrible. The resolution is always terrible. I almost always would prefer small, old-fashioned radiograph. The X-rays are blurry and the resolution is terrible. In addition, the need to overexpose the patient is very, very frequent in order to get a better image. That's an interesting point. I can't speak to what you've gone through. I will tell you that you have to make sure when you get digital X-rays from other practitioners that if the copy on the film, number one, it needs to be on photo paper. So many times they're not. And secondly, if you can't get a good view of them, then I would ask them to email them to you, because a lot of these digital x-rays are much better shown on a computer screen. That's what they're made to do. They look better on the screen and their resolution is better. I can't speak to any other system than the one I use. Our images are good. If we get a blurry image, the patient moved. I don't think it's a sensor problem. Sometimes the images are blurry and the patient is not an easy candidate for x-rays. So I can't speak to what you're going through, but I wouldn't, in any question, dismiss the quality of digital x-rays as a whole. Do you have a certain preference in digital software? I can't. I mean, I can only go by what I use. I don't use multiple digital softwares. Usually when you buy your digital x-ray system, the digital software comes with it, or you can go to a third party. You have to do some more research for that. Next question. How sensors record the image, please? Again, that's beyond the scope. We only have about a couple minutes left. So you can certainly ask your manufacturers that you're interested in to explain that to you. Let's see what else we got. Incorporating digital software as a subtitle under investigation session. Yeah, I mean, somebody just asked about digital x-ray software. That's a whole nother show. There are hundreds of different softwares out there. Some are much more expensive and more robust than you actually need. Most general practitioners, if you're a general practitioner or maybe even a pediatric practitioner, you don't need some of the robust things that some of these softwares can do. If you want to play with it, you certainly can do that. Is a dental digital image quality standard? No, I don't think there's a dental digital image quality standard. I'm not 100% sure of that, but I don't believe there is. How are the images wiped out from the plate? Great question. I apologize for not bringing that up quickly. The x-rays have to be erased. The plate is actually erased, and the way it's done, in the old days, there actually was a separate eraser. Now it's actually in line, so as it goes through the x-ray machine, as it goes through the processor, it erases the film, and they're ready to be used again. Then one of the advantages that we eliminate the use of x-ray cone, isn't it? No, you're still using a cone. You're still using a regular x-ray machine to take your image. You're just lowering the dose rate. So in terms of rectangular versus cylindrical collimation, that's a whole different presentation. We use the sensor, which is very uncomfortable to most patients. The VSP appears to be like film. Do you reuse it, or is it like film? No, it's not one-time use. The question is it like film, or is it one-time use, or do you use it over and over again? Nope. You use it as over and over again until that sensor doesn't work anymore. And normally, if you teach your staff what to look for, they will look at the films and they will say, okay, this one's no good. It's time to throw it out. Sometimes they get scratched, they get bent. So we can do that. Have not any problems you have mentioned with the sensors with DEXIS. Well, everybody's different. I mean, you go on Dental Town or some of the other blogs and you'll have various different positions in terms of not everybody's going to have the same experience. What we had with our sensors, we're not big fans. We've tried multiple different sensors. It didn't work for us. And I think for most practices, the phosphor plates really work well. What kind of digital imaging would you recommend for portable field work? That's a good question. I don't know. I mean, I think you can get away with both. It depends on if you have a place for the processor. I think for digital field work, I think you're going to get more out of it if you're doing a really large volume of patients, that the scanner is better. Isn't DICOM a standard used for digital images? DICOM is used for CT scanning and cone beam scanning, not for the type of digital images of bite wings, PAs, and Panorexes. Well, ladies and gentlemen, one more. I can get a great image with sensors when I use a handheld x-ray unit. The necessity for patient to bite is lessened. I think that's a good point, using a handheld x-ray unit. Not everybody is into the handheld x-ray unit concept. There's been some positives and negatives that we've heard about it, but that's an interesting point, and I thank you for that. So thank you, everybody. It's about a minute left, so I'm going to have to get off. Thank you for your comments. There was a typo or two that some of you pointed out, which I always appreciate. Being a lecturer, sometimes that happens. You don't always, I'm not an English teacher, but thank you again for your time. Thank you for listening. Thank you for coming in all over the world, and I wish you a good night.